Hello, my name's Tom Stinchcombe. I'm a medical oncologist who specializes in thoracic oncology at Duke Cancer Institute in Durham, North Carolina. As we've adopted first-line osimertinib, and this has been for our patients with EGFR mutation, and this has been a tremendous advance for the patients. The inevitable question, what to do at the time of disease progression, and what are the options? We all hope that some of our patients will remain on it for years, but most patients do progress at some point. And I think when I kind of look at it clinically, there are a number of different types of progression. There are some patients who have sort of slow progression, that they're asymptomatic with really minimal growth on the CT scans. And those patients, I feel very comfortable continuing the osimertinib in close surveillance to see if they can sort of continue the osimertinib for a longer period of time. There are some patients who have disease progression in one or two different sites. And those are the patients I would think about doing radiation therapy, generally SRS, to those sites of disease progression, and then trying to continue the osimertinib. I think the more challenging clinical situation is when there's sort of diffuse or symptomatic disease progression, and what's the best therapy to do at that time. I think we have been doing some studies looking at molecular testing at the time of disease progression. Today, we found that there's really been multiple types of mechanisms of resistance identified. Does not appear to be one dominant type of mechanism of resistance. And so what we see is 10 or 15% of patients will get MET amplification, HER2 amplification, as well as occasionally the C797S resistance mutation. And I think most of the time I do a ctDNA test at the time of disease progression, with really the goal of getting the patient onto a clinical trial that's targeting it. We've seen some preliminary results of osimertinib plus a MET inhibitor for patients who've had a MET amplification in this situation and shown some response rates. So I really look for that as a potential trial option for patients. I think the field is very much at the beginning, and I think we really need to continue to do ctDNA and ideally tumor biopsies, ideally inside a context of a clinical trial in a somewhat standardized format. Because unless we really understand the mechanisms of resistance, then we'll never know how to pursue our drug development strategy in terms of developing what to come after the osimertinib. And I think that this is going to be sort of a labor-intensive process in terms, because the prevalence is very low of them. But I think we still really need to take this on as a field to really determine what's the best strategy going forward.